Hello, everyone. I'm Michael Dahl, Director of Risk Management at Professionals Advocate Insurance Company. Today, we'll review lessons learned from a closed claim study that examined professional liability claims since 2018. Our goal is to identify contributing factors that make claims difficult to defend and discuss strategies to mitigate these risks and help improve patient safety. We'll cover a study overview, some major contributing factors, and practical strategies for documentation, team collaboration, and patient communication. Lies over 1,700 closed claims initiated since 2018. We focused on factors impacting our defensibility in these claims. 21% of claims had factors that reduced defensibility. This means that some contributing factor led to a possible injury in the patient's care. This doesn't mean malpractice. This doesn't mean bad patient outcome, but other factors such as communication and documentation, which we'll get into. They highlight the importance of proactive risk management, especially documentation and communication. So what are the main factors that make claims harder to defend? Let's discuss those. Major contributing factors. So 38% of our claims included documentation errors. This includes incomplete or unclear documentation as the top issue in a case. It creates legal complications years later. This includes incomplete or unclear documentation in the medical chart, issues with drop-down boxes, pre-selected items, and carryover from other charts. In 68% of claims, there were coordination challenges. This included multi-defending cases. Poor coordination leads to conflicting records and higher indemnity payments. Multi-defending cases can lead to finger-pointing amongst providers, which leads to more payments. Additionally, 36% involved patient communication or poor communication with patients. This could mean miscommunication or insufficient informed consent as another major contributing factor. Try to think about your own practice. Where do you see the biggest risk arise among these three? Is it documentation issues, patient communication and encounters, or is coordination challenges with your care team or other providers? Let's dive into some strategies to address these issues and discuss some real-life scenarios that we actually defended. So some strategies for effective documentation. Timely records. Document patient encounters promptly when they're fresh in your mind. Don't wait sometimes weeks, months later to try to remember how that visit went. Try to do this within 24 to 48 hours so that those interactions with the patient are fresh in your mind. Use professional language. Avoid subjective comments. Stick to neutral, factual language in the patient chart. Use comprehensive treatment plans. Include differential diagnosis, treatment goals, and alternatives. If you must deviate from your standard practice, document your thought process and your reasoning behind it. Never alter original entries. Use dated addendums. Altering your records in any way could lead to coverage issues, such as loss of coverage. Avoid going back into the record after receiving the record's request. If you do that, EMRs have metadata where plaintiffs can find out when and how often you access the chart and what changes if you made. So documentation is key. Before we talk about care team coordination, let's look at a real-life scenario. Try to put yourself in this physician's shoes. A busy primary care physician sees a 45-year-old male patient for persistent abdominal pain and fatigue. The physician conducts a physical exam, discusses potential GI issues or infection, orders blood work and an ultrasound, and verbally advises return if symptoms worsen, plus follow-up on results. However, the EHR notes are sparse. A normal abdominal exam checkbox, brief symptoms, and orders lacking rationale, differentials, or follow-up details. No record of patient questions on risks or alternatives were noted, or education materials. 2 weeks later, undiagnosed appendicitis leads to an emergency surgery, sepsis, and complications. The patient sued the physician for failure to diagnose, poor communication, and delayed follow-up. In court, templated EHR notes show copy and paste inconsistencies, outdated alert and oriented status, missing timestamps, and uncharted contact attempts for abnormal results. The plaintiff's mantra was, if it wasn't charted, it didn't happen, and that prevailed. The jury awarded the plaintiffs. So try to think about ways that that scenario can be used in your own practice. What did they do wrong? What should have they documented? What should have they discussed with the patient and then documented that? Try to use these strategies in your own practice as we conclude the rest of this presentation. Multidisciplinary collaboration. This includes your care team, such as advanced practice providers, APPs, PAs, NPs. Clearly define their roles, especially those that work under you. Align treatment plans to reduce any conflicts. Document your involvement as a physician in the medical record, and limit your supervisory load to be in compliance with any state or local regulations. Miscommunication practices. You secure platforms and in-person discussions for critical issues. Maintain an open line of communication when working with other healthcare professionals outside of your practice, and relay all necessary information to necessarily affect the handoff of the patient to other providers. If you have a problem, if you have a question, simply pick up the phone and call if you have any issues, and document those interactions with other providers in your chart. Finally, before we move on to our next item, let's talk about another risk scenario. The primary care physician referred a 60-year-old patient presented with chest pain and shortness of breath to a cardiologist for urgent evaluation. The referral note in the EHR is vague, mentioning only chest discomfort, but omitting details like symptom duration, associated nausea, or ECG findings. The physician doesn't call the cardiologist to discuss the urgency. The cardiologist, assuming non-urgent stable angina, schedules a patient for a stress test in 2 weeks. Days later, the patient suffers a myocardial infarction requiring emergency stenting and prolonged hospitalization. The patient sues both physicians for malpractice, alleging a delay in diagnosis and poor communication. In court, the incomplete referral note and lack of verbal handoff weakened the defense, as there was no shared urgency or clinical context documented. As a result, we settled this case, which could have led to finger pointing in the courtroom. Think about ways we can improve upon this situation. Simply calling the other provider and letting them know the urgency is one. Documenting that phone call maybe would have saved this case from settlement. Let's move on to the next. Enhancing patient communication and consent. Clear communication and miscommunication can drive claims one way or the other. So clarity is key. Use language that the patient can understand. Know your patients, know their education level, and know their level of understanding. If interpreters are needed, use them. For informed consent cases, it's important to remember the 5 elements which should be included. Be sure to cover the nature of the ailment, the nature of the proposed treatment, the probability of therapeutic success, and any reasonable alternatives and material risks of the procedure. Tailor those discussions. Use interpreters, visual aids to confirm mental capacity. Give your patient time to reflect on the information discussed. It shouldn't be done over one visit. Consent discussions, in most instances, can take several office visits for the patient to gain a full understanding of what it is they're getting themselves into. Finally, confirm the patient has given consent without coercion, influence, or manipulation from anyone. Equally important is to document all discussions thoroughly in the patient's chart. Going beyond that, clear communication with patients extends beyond the informed consent discussion. Being open, respectful, having that open, respectful dialogue can make a meaningful difference in their care. What we found is that bedside manner matters. By addressing the patient's concerns early, you may prevent small misunderstandings from escalating and eventually becoming a claim. Finally, when communicating with patients via asynchronous means like text messages or patient portals, avoid providing treatment through text. If a patient messages you about an acute situation, speak with them to evaluate their situation and implement a plan. Be sure to have clear policies in place for how to negotiate these or navigate these situations with patients. If a patient needs to go to the emergency room, don't be afraid to tell them. Briefly, let's talk about one last risk scenario. A surgeon schedules a 50-year-old female patient for a cholecystectomy. During a rush preoperative visit, the surgeon briefly mentions gallstone removal, but skips discussing risks like bile duct injury, bleeding, alternatives like watchful waiting, or the procedure success rate. No visual aids or follow-up time are offered, and the consent form is signed without documenting the discussion. Post-surgery, the patient suffered a bile duct leak, requiring additional surgeries. The patient sues the surgeon, alleging inadequate informed consent, and in court, the sparse EHR and lacks evidence of risk disclosure or patient questions, undermining our insured's claim of verbal discussion. The plaintiff's attorney argued that the patient wasn't fully informed. The jury awarded, citing poor informed consent. Again, going back to those 5 elements, we don't know for sure if all of those 5 elements were met because nothing was documented. Again, it goes back to documentation and making sure that the patient is fully informed. Think about ways in your practice you can improve your informed consent processes and how to make that easier on both you and the patient. So finally, we'll dig into a summary of our risk mitigation strategies and move on to some additional information. Some key takeaways. Again, comprehensive documentation, team care coordination, and clear patient and provider communication is essential. Timely, clear, and thorough documentation is vital to support legal defense even years later. It's the only thing we have to rely on. We can't go on memory or other pieces of information. The record is what can defend you. Team coordination. Again, effective collaboration among healthcare professionals reduces risk in multi-defendant cases and reduces the risk of indemnity payments in those cases. In most instances where that's not done, we see situations where there's finger pointing amongst providers. Inevitably, what happens is that the jury blames everyone, which means everyone has to pay. Clear patient communication. Transparent communication during informed consent prevents misunderstandings and improves patient satisfaction. So again, this shouldn't be done over one visit. It's a series of visits and documenting each of those discussions each time. Thoroughly go over the intended risks of the procedure, potential outcomes, the alternatives as well. That is equally important. Use handouts when necessary and make sure the patient has time to go over their decisions without coercion. And finally, proactive risk management. Implementing these proactive strategies enhances patient safety and optimizes outcomes and potentially lowers adverse risks. So these principles remain relevant today as they have been in the last 40 years that we've been writing insurance. But if you have the information we've examined today, you might be able to prevent them in the future. For more in-depth discussion on these issues and among others, please follow us on LinkedIn. There's additional information on our closed claim study, as well as other company-wide information that you might find useful in your practice. Additionally, we'll have a newsletter coming out in a few weeks on our lessons learned from the closed claim study. Please keep a lookout for that. Thank you for your time today. Have a great day. Thank you.